first lab, okay, where we did the ortho stuff. I want you guys just kind of testing yourself as we go through it. I'm going to give you time. We're going to show you things. We're going to go over it. At the end, I'm going to show you just a couple of basic little things on a chest x-ray, right? But use this to have an idea of where you're at in reading the chest x-ray, where you're at. Some of these are going to have vignettes, some of them are not. So just use this to kind of give yourself a barometer of where you're at. The test is in 1 week, right? No, I have not finished making it yet. So, but have an idea of kind of where you're at on it and then ask the questions. This is a good test for you to get an idea of that. So the next 2 days you study, you prep, you come in on Thursday at lunch for that optional Q&A to kind of get all the last little bugs or confusions or muddy water ideas out. So that way we can get you prepped to go into the weekend getting ready, okay? Make sense? All right. You cannot succeed in clinic and chest x-rays without having a systematic approach to reading them. So remember all the way back weeks ago to our very first one. Simple man, simple things to remember. I like the alphabet because I learned it in the 5th grade. You know, it took me that long. No, A, B, C, A through I. Going through this is my process. Again, does not have to be your process. Clinic, which is where you're all going to be. Do not do this on my test. You will run out of time. If you try to do this process on the test, you will run out of time. Read the stem, the main question, read the choices, and then know what I'm looking for, and then look through all these things specifically to rule in or rule out the answers on the exam. However, that is just to get through my test. You need to come up with a process when you're in clinic. This is how you don't miss stuff, okay? All right. So, no vignette. We play the game, and just look at it, go through the process now, right? This is not an exam, so I want you to practice it. Take a look, see if you can find it. There may or may not be more than one. Sometimes there is, sometimes there isn't, but that's life. I'll give you a little while. Alright. Yes or no? You just be thinking in your head. You don't have to say it out loud. You can say it out loud if you want. Okay. We'll get there in a second. Did any of you raise suspicions on this? What are we looking for? What's hard to see? At least 8 ribs. Well, can we appropriately, here's the question then. It's hard to see at least 8 ribs. So I love that you know that's something we're counting. Can we appropriately count our ribs on this x-ray? What's the issue with it? Where are the apices on my chest x-ray? Is that going all the way up to my cervical spine? Can I see where that first and second rib come in? Not really, right? So if you were to get this, you couldn't use it for a full evaluation. You definitely couldn't use it for rib counting because I don't have the top of my thorax. I can't see any cervical spine up here, all right? Now, luckily that doesn't do anything for potential cardiomegaly, which is what I'm asking in that aspect, but I just wanted to know, did you go through it in your head? This is a test on you. Did you look at it? Did you go, huh, I'm missing part of the anatomy, right? Because in clinic, you definitely need to know that. So then this goes over again. What are the things for a technically adequate x-ray, right? What are we looking for? There were 5 things we talked about way back when that we evaluate to figure it out and know, is this a good x-ray to make diagnoses off of? Those are the 5 things. Remember, we're looking for enough exposure. So what's that exposure? Primary thing for me, I want to be able to see my lung markings and my vasculature so they're not too dark and burnt out, which I do. And then also, can I make out my thoracic vertebrae in the shadow of my heart? I can. If I can't see the vertebrae or I can't see my lung fields, then that's either over or underexposed. Right? So we're good there. Magnification, it's a PA, I think we're okay. If it was an AP, I would want it labeled and I would know that. Kind of hard to tell on chest x-ray unless I give you that AP aspect. Inspiration, counting the ribs, that's when we come back to 1, 2, 3, 4, 5, 6, 7, and really 8, 9 are kind of up here, but I can't see them. So there is enough ribs, but with it being cut off, I don't know that, so I can't count that to be confident that there's enough there. There is enough for inspiration on this one, it's just the top was cut off, but without that upper part, you really don't know because you can't count those ribs well. Angulation, we can look at our clavicles and sternum. Is it rotated? Is it, that's rotation. Angulation is different, sorry. Rotation, is it rotated? Maybe a little bit, right? Angulation would be those clavicles going up, like if I angle the tube up. It doesn't happen very often, but there's no angulation issues on this one. So for those that said we saw some rotation, there it is. Now, does that really matter? It can, depending on what my diagnosis is, right? Would that explain? Did anybody notice how it looks like the right atrium is maybe a little bit larger than most of the normal chest x-rays we saw? Right? There's a little bit more here. Usually it just kind of came just a little bit out to the edge on either side. A little bit more on this one. So now is that a large right atrium or is that due to the rotation? In this case, because I let my clavicles up there, due to the rotation. If they weren't rotated like this, then I would suspect possible right atrial enlargement. So now that we've covered the basics, let's get into real stuff. 24-year-old male presents after an altercation with chest pain and shortness of breath. Tachycardic, borderline tachypnic, technically normal, it's not over 20. Temperature is 99, meh. O2 sat's 95 on room air, technically normal, right? But he's 24-year-old, so that's a little concerning, even though it's still a normal vital. Physical exam shows bruising throughout the chest with equal breath sounds bilaterally. Based on history and image, what is the abnormality noted? Now, here you're going to go through your stepwise process. But again, on the test, look at my 5 choices. We covered a lot of abnormalities. Figure out which ones I want you to pick from. It'll go faster, okay? But this is clinic, so take a look at it, figure it out. And if you learn, while you're looking at it, if you learn some of the pathophysiology stuff we talked about, some of the way patients are going to present, or the most common way to get certain abnormalities, you might already have an idea in your head what I'm trying to go for. That's called forming a differential, so you're already starting to do that, which is good. Good, we need some more time. How many saw the pneumothorax? Good. How many expected a pneumothorax but had a hard time seeing it? Okay, good. So expecting a pneumothorax, we're getting there, right? You got an idea, hey, I'm looking for a pneumothorax, but what tries to throw you off in this vignette? Equal bilateral breath sounds. Is that possible in a pneumothorax? Absolutely. What if I auscultated here instead of up here? Right? What if I auscultated here? This is my first pairing area. I didn't go up here. I'm going to have equal bilateral breath sounds because I didn't hit the area where the pneumothorax was. What was your question, sir? Yeah. Yeah, right? And so it is, right? In your tension's unlikely, because those are usually massive pneumothoraces that are starting to push it, but regular pneumothorax, If you don't put that stethoscope in all the right areas, and you guys learned like the 7 paired areas, right? What's gonna happen, you're gonna go out in the clinic, you're gonna be like, I'm listening to the 2 paired areas, thank you, or 3, right? But that's why we encourage you, that's okay for your standard patient who comes in for knee pain, ankle pain, toe pain, right? Great, do a quick cardiopulmonary exam, listen to the heart and lungs, right? But then when you have a cardiac or a pulmonary complaint, do your full chest exam. Do the 7 paired areas. Look at it all so you don't accidentally miss where the pneumothorax is and maybe you get absent breath sounds, right? And that's why we say we use the image as adjunct. Okay, so there was the pneumothorax on this particular X-ray. All right. What's the difference between this one and a tension pneumothorax? Mediastinal shift, correct? Mediastinal shift, or vitals. Look at my vitals. Does this look like an unstable patient? Right? He's slightly tachycardic. Right? I would like to give you blood pressure, right? I don't have blood pressure on here, but he is slightly tachycardic. But in reality, he's not quite tachypnic yet. He's not hypoxic at this point, right? So by the letter of that, he's not unstable. So I would consider this a stable patient, right? Because I promise you, somebody with a heart rate of 109, you are not calling unstable. Because if that were the case, every single person in here the other day was unstable halfway through their PT test, probably a third of the way through their PT test, right? So a 109 heart rate, not unstable. You got to take all the vitals together to do stable versus unstable. So stable patient. So how do we diagnose tension pneumothoraces? Clinically. Is imaging important? Sure, imaging is important, but is that how I need to diagnose? Not a tension pneumo, right? We do that clinically. So this one, I have some tracheal deviation, just a little bit, but these are the things that are different from it. Like it's just a little bit. I still would not call this a tension pneumo, okay? Patient is pretty stable. I don't have a whole lot of mediastinal shift. This right atrial thing, look at the rotation I have in my clavicles. See my rotation? That's way out here. There's a big gap. That's why I have a large right atrium. That's why understanding that rotation, looking at it is important. It makes an abnormality not actually an abnormality, right? But these are the 3 things you're looking for to differ between image-wise between a tension and a regular pneumothorax. Tracheal deviation, mediastinal shift, and the cardiopulmonary compromise is a fancy way of saying are they stable versus unstable. Okay? Tracking, yes, good. Did you see anything else? See anything else? What?
I just wondered, is that normal for the? I hit on a cost-effective angle. It looked like it was blunted, just like because the other one's so drastic, but it's probably because it's twisted.
Yeah, it's the rotation a little bit, but they're pointed and down there right up against the thorax wall. So I don't see any pleural effusions or blunted or cost-effective angles, but I do see some subcutaneous emphysema. Ah, subtle. Subtle. So if I have a pneumothorax and subcutaneous emphysema, where else could we see air? How many of you picked up on the pneumomediastinum? You see what can happen when we just get excited because we see a pneumothorax. We think pneumothorax. The patient screams pneumothorax. We see the pneumothorax. Yes, we're done. It's a pneumothorax. Pause. Go through your stepwise process. I have the air around here. Hard to see the air in the great vessels, but what did I teach you about that? I got the subcutaneous emphysema. So pericardium just became pneumomediastinum because of the sub-Q emphysema. You see how quickly some of these things can kind of get inside. Questions on that? Does everybody see how that works? Yes, sir. Right up in here. There should be no air. This is all muscle and skin. I should have no air. It's not as prominent as the slides we saw in the lecture, but really I got this radiolucent area sitting right here in the soft tissue on both sides, and there shouldn't be any radiolucent area there. For those over on this side, right here, and right here. I'll go back to the slide that shows the arrows. Okay. Does the process follow? How like the vignette's like, okay, I think pneumothorax. Okay, boom, I see the pneumothorax. But caution yourself on stopping and going through it, right? Pneumothorax is accurate, but there's also a pneumomediastinum here. So if I gave you this question on the test, and I asked you to pick out the abnormality, can 3 of my choices be subcutaneous emphysema, pneumothorax, and pneumomediastinum? No, because they're all on here. But what I can do is I can put pneumopericardium on there, because this isn't a pneumopericardium, it's a pneumomediastinum, right? Because of the air in the great vessels and up in the subcutaneous emphysema, that makes the mediastinum. I was gonna say I don't think that's what I do. But I gotta get you to think clinically, think through this stuff, right? Because you're gonna see these patients someday. And when you learn how to manage them, your management is important. You don't do that here, but you will learn. But if you can't identify, right? If you can't identify, so think second, third order questions, things like that, right? Treatment, management, diagnosis, that's where we're at, okay? A lot of times people get hung up and focused on like treatment, how to treat the conditions. That's important. You need to know how to treat conditions. You're gonna learn all that next semester. You're gonna learn all that in your senior semester. But if you can't identify the diagnosis, then you can't treat the condition, right? If you can't identify the diagnosis, then you don't know what the management step is. You don't know what procedure you need to do or what the next imaging type thing is. And so it all kind of works into itself and all plays together. So it's just as important to know the treatments for conditions as it is to be able to identify them, right? And you will learn a lot of these in Pullman cards and GI and all that. Okay. Yes? Oh yeah, ma'am, go ahead.
Sorry, I was just gonna ask, so it's for the, to make it the,
Yes. So pericardium would stop here, okay? And then because I have the air around the great vessels, now we're in the whole mediastinum instead of just the pericardium. Okay? Yeah, good question. I recognize that the quality overall is not great, but it's enough to answer the question. And sometimes that's just the nature of these things. Yes, sir?
Are the pulmonary vessels obscured because of like rotation, or is that just
On this one?
no,
So, yeah, a little bit of the rotation, right? So I got more right atrium, so you notice how like the aortic knob is not as prominent and some of that pulmonary vascular is not as prominent. It's hiding more behind the spine because of that rotation. Yep. Yeah, good thought process. All right, so 36-year-old male comes in with fever, chills, shortness of breath for 2 days. Physical exam has mild crackles. Based on history of physical exam, what is the most likely diagnosis? Along with the pictures I'm giving you. Okay? Do you remember what things are called? What phenomenon is on the lateral film? Spine sign, potentially. Definition of spine sign. Should get darker as we go down. Okay, what about the frontal film or the PA film? The silhouette sign, right? You guys knew you expected pneumonia. Can you tell me where? Right lower lobe is what I'm hearing. Good, good. So what are my clues? Well, A, I gave you a PA and a lateral. So that in itself, you remember where the lobes are, that's enough for you to call right lower lobe, okay? But if I just gave you a PA on this, because of the silhouette sign, which is hiding the right hemidiaphragm. I can't see that. If I gave you just that, it's not a definitive right lower lobe, but if you had to make your best educated guess with the information presented, if you go back to that chart, it would help you remember that the silhouette sign of the right hemidiaphragm means right lower lobe. So understanding that will help you get to where you need to be, but I gave you both. I gave you this both pictures with the spine sign, so you can be able to put them together like this and go, okay, they're both in the red area. This is a right lower lobe pneumonia. Okay? As a reminder, when you do that, use your PA image to figure out what lung first, then use your lateral to determine what lobe. Because remember, this is both the right and left lung on this lateral, right? This is both the right and left lung superimposed on one another. So you use the PA or the frontal view to determine what lung the abnormality's in, and then use the lateral to help determine the lobe. Put that together, you can be definitive in saying right lower lobe pneumonia. Make sense? If you only have the PA, use that silhouette sign chart to give yourself a probably, and sometimes that's all you're gonna have. Really, I say keep saying PA, but it's gonna be an AP image because they're gonna be in a hospital bed or something along those lines. All right, that's doing good. 54-year-old obese male with shortness of breath for 12 hours. No trauma, no fevers. Look at your x-ray. All right. How many of you found it?
It's an organ donor.
Organ donor.
No heart.
No, it's there. It's there.
Just got lordosis.
It's there. It is hidden by something, but it's there. How many found the atelectasis? All right. I will admit it is difficult to see on the PA, but when I use my lateral, it tells me that we kind of looked at something. I can see something very clear that I normally cannot see because of the collapse. So what lobe are we looking at? First, left side appears overall grayer than the contralateral side, so much so that I'm starting to obscure my cardiac silhouette. I almost just see atelectasis here and not a whole lot of heart. It's there, but the collapse of the lung tissue is causing that obscurity. Yes, sir.
So is it also kind of pulling the heart a little bit?
Yes, it is pulling just a little bit as well, correct.
That's what.
All right? So then, first you see that, and then we notice that fissure. I'm going to go back. Look at my fissure. Look at how dense my upper lobe has been. It has completely collapsed on itself. And it allows that lower lobe to hyperinflate and fill that area. Now the next one, we didn't really go over it. This is an old lab slideshow back when I focused on it, so don't get so hung up on whether or not you noticed that the high lobes were higher than the other. I told you your level, not really too worried about that. If you focus on the atelectasis and kind of the collapse of the lobe and the fissure and the little triangular shape, it's hard to see here because of the heart, but the nice part about this is when it's in this area, it's typically that left upper lobe, and the lateral gives us a lot of information on that. Left upper lobe atelectasis. We see how we got there. All right. Bam. So the left lobe is right here, up against what we call the sternum. This is the fissure, and the rest of it is the lower lobe. So the upper lobe is this area right here. Let me see if I can draw it out there for you. So all of this is that left upper lobe that has collapsed. That's the atelectasis, right? And so because of the collapse, it all bunches up and pulls, which is why we can see that fissure so well, because of it's more dense than the other lobe, whereas normally it's kind of hidden around. And then this guy kind of comes up and just takes up all that space, the lower lobe. Okay. On the PA, it's this guy right here, kind of pointing back in here. That's your atelectasis, is all in this area, which is kind of why it's obscuring the heart, and it's hard to make out some of the heart shapes. I don't have right atrium because of what he mentioned, right? That right atrium is being pulled a little bit behind the spine because it's that left upper lobe atelectasis, pulls it over a little bit, so that's why I can't see any right atrium. Okay. Sometimes you'll have positive neuroscience. 72-year-old male, past medical history of diabetes. That's hypertension, not hypertension. That's a HTN there. Coronary artery disease, hyperlipidemia, presents with chest discomfort and shortness of breath for 2 weeks. He states he's been sleeping in a recliner, which has improved his overall sleep ability. Based on the history and image, what is depicted by the yellow arrows? What is depicted by the yellow arrows? Can I put congestive heart failure as an answer? Yes. Would it be wrong? Yes, because the question is asking you what are the yellow arrows pointing at, not diagnosis. Read the question. Right? Read the question. But yes, it is fluid in the fissure. But now that we've already established what the disease process was, I'm confident you guys knew exactly what that was going into that with all the comorbidities. What other signs do you see in your head? All kinds of stuff, right? All right. How many of you found a parabronchial cuffing? Okay. Parabronchial cuffing. Remember that fluid going around the bronchioles, peribronchial, being able to see those little circular airways that we should not be able to see. How many of you were super advanced and found the curly D lines? I'm going to go back. Now, see the red lines there, right? I'm going to go back. Look at it again. They're right there. Come on, guys. Not going to make you pull out curly D lines, but showing you that they are a thing. They are there, right? But there they are. How many saw the blunted costophrenetic angles? I already heard some people say that, right? So I got the blunted costophrenetic angles. How many saw the cephalization? Remember how to look for cephalization. That often gets overlooked when you're reading these x-rays and trying to find abnormalities. Remember, as we go up, I should be more radiolucent up here than down here. If the lung markings, the vasculature, is as prominent as it is in the lower third, that is cephalization. Okay? Looking at the prominence of the vasculature or lung markings. Pulmonary edema, we already talked about that. So, well, we talked about 2 kinds of pulmonary edema. So, based off of what we're looking at here, what type of pulmonary edema do we have?
Interstitial.
Interstitial from CHF. Remember, congestive heart failure is an end-stage disease process. CHF is caused by something else. So your job a lot of the times when you see a patient with congestive heart failure, why? What caused it? You don't just go out somewhere to a party and get a virus with somebody and get congestive heart failure. This is an end-stage cardiopulmonary disorder. Okay? So anybody with long-standing hypertension can lead to congestive heart failure. Right? Pulmonary arterial hypertension can lead to congestive heart failure. Multiple small PEs can lead to congestive heart failure. Anything that's not working in that area can lead to CHF. This is end stage. All right. How we doing? Doing okay? Got a couple more vignettes. Helpful? Hoping it's helpful? Maybe not. 30 or 55-year-old female with past medical history for hypertension, the correct abbreviation this time. Breast cancer, currently undergoing chemo, comes in with shortness of breath of 3 days. What are we concerned about? Based off of the image. Okay, so I'm hearing effusion. Where? Medical term of location? Right side. Hey, I'm happy you at least know it's the right side, right? Remember opposites, so that's important to remember that. So that's a step in the right direction. Where is the fluid building up at? What was that? Pleural space, pleural effusion. That's what I was trying to get at. That's what I'm thinking. And some of you may have already said it, and I just didn't hear it, and I apologize if that's the case. Right, it is a pleural effusion. This fluid is not in the lung tissue. This is in the pleural space. It's a pleural effusion. That's kind of what I was trying to get you guys to. Terribly, might I add. I did not do a good job directing you. I apologize. I will not be a conductor when I retire from the military. All right, that was it for this one. Just can you notify the pleural effusion on that? Okay? There. 23-year-old male presents with mild chest pain for 12 hours. He has no significant past medical history. Good Lord, I need to edit some of this. Review a system is otherwise negative. Physical exam reveals no abnormalities. Based on the history and image, what is the abnormality seen in the image? Okay? It's not the big blue rectangular box. It's subtle. Go through your process. Go through your process. All right.
Blunting.
How many of you getting good at this and found the right pleural effusion?
Close to.
Look at the difference in the sharpness of the right versus the left costophrenic angle. Notice the blunting. Notice how it doesn't go all the way down into that little sharp point, but it does on that side. Okay? What is that? Oh, go, yes, sir, go ahead. Mhm. Unlikely, because if I see this, is that really minor? It's minor on the image, but what does that tell you? How much fluid?
300.
At least 300 milliliters of fluid in the pleural space. Remember, these are the anterior costophrenic angles. So is that really minor? Not really, right? Because we got at least 300 milliliters of fluid in that pleural space if I can see it on my PA. Looks minor with just this though, if we don't understand that pathophys and that volume aspect. Okay. What's right there? Got the slides? No? It is hard to see because you follow your carina down, or your trachea down, you got your carina, and so yeah, you follow your trachea, you got your carina, and what I'm trying to circle there is the right main stem bronchus.
Oh, yeah.
right? Because we can see our trachea come down, it splits, it bifurcates, left main stem, right main stem. That's what I was trying to show you there.
All over it.
Now you got a hint of kind of what I'm going for. So what area am I circled here? Good, the aortic knob, I like it. Okay, where is the right sixth anterior rib? Oh man, he taught us how to count these, I think. Might have been studying farm while he did it, but I think I can do this. It's okay, I went through this program, I know how it works. But now the question is, do you remember how to do it? I'll give you a few more seconds to try to count it out. Remember what I taught you about counting the ribs and how to do it? All right, how many said right there? 1, 2, 3, 4, 5, 6. Anterior ribs. If I was going posterior, so just for those of you who accidentally counted posteriors, I would go 1, 2, 3, 4, 5. That would be number 6 posterior. All right, go back and look at the rib countings, know how to count ribs. Remember, the anterior ones are the ones that have that more steep kind of decline. The posterior ones are the ones that are more transverse or horizontal. And I highly recommend when counting the posteriors, you start with your anterior and go, okay, there's 1, there's 2. So then that's going to be 3, 4, 5, 6, 7, 8, 9, that kind of thing. To help you so you don't get confused up here on where 1 and 2 and 3 are. Okay? All right. There it is numbered again. Where's the minor fissure? Remember what I said. You may not be able to see it on the x-ray, but definitely know where the general location is. So if you see an abnormality in that area, you know it's supposed to be the minor fissure. Not going to give you all the time to try to find it, but it's going to be right in that area. All right, I can't really see it. Can't really see it, but know that it's in that general area because when you get those abnormalities, like we saw with the yellow arrows in the fluid and the fissure, a lot of times it's going to sit right in that area, so you kind of know where it's at. What's this? Yeah, the hilum. What's this? What do we call that? Retrocardiac window or clear space. What would make it abnormal? First of all, if it was abnormal, what would it look like? It would be more, the space would be more radio opaque because it's likely due to what? Well, let's say a couple of things, but concerned about cardiomegaly, right? If the heart is infringing over on the spine, or we could have a pneumonia, some type of consolidation mass, or something in there that's not supposed to be there. Either one of those. Where's the left heavy diaphragm? It's the top one. It's the top one. Okay. Why can't we see the anterior portion of the left heavy diaphragm? What's hiding it? So think about it. I do an x-ray, left side's against the film, right? Shooting it. Why can't I see the left portion of the hemidiaphragm? It's silhouetted by the heart. It's silhouetted by the heart. And that's how you can tell the difference between the left and the right, is the right on the lateral, you will see the whole hemidiaphragm. The left, you will not. Where's the aorta? You can see it. It does stand out. Right there. Candy cane. All right. Costophrenic angles. Oh, yeah.
Is that the esophagus in front of it?
You cannot see the esophagus on an x-ray.
Is that straight up?
This guy here?
Radiolucent thing?
Probably part of potentially trachea or main airway. Because remember, the esophagus won't be radiolucent because there's no air in it.
Oh, I actually I promise I really meant that little.
So it is possible that that could be part of the trachea. It's not on most x-rays like that all the time, so we don't look at it and evaluate it in that way. We use the PA for it.
Would have been a lot cooler if I said trachea.
It would have been a little bit cooler. I don't know about a lot, but at least a little bit. What's up?
So what are those vertical lines right above the aorta? Like,
Right here?
Yeah. Like,
These are your scapular spines. They don't have their arms kind of out of the way enough. They just got projected in there. It all depends on positioning, right? Where can I get those? Can I get the scapula out of the way? If they're like brought in like this, then part of that scapula is going to infringe and be like superimposed on that spine area. And so that's what that is there. Not good patient positioning by your radiology tech. Okay. Costophrenic angles. There and there. How was that? Beneficial, not beneficial?
Got a lot of stuff.
Right? Got a lot of stuff to study up on, right? So that's the chest x-ray portion. What this was designed to do is to reinforce, right? Because we did this weeks ago, right? Reinforce your stepwise process. And one of the biggest things, remember to read the question of what I'm looking for. That will help you on the exam immensely, because that's what you have to answer. But before you get into the image, read the question. But then also when you get to your clinic, remember, first abnormality, don't be excited like the kid on Christmas and take it and throw it away and say, where's my next patient? Where's my next present? Let's go. Take a second, really look at it, see what's inside the gift like on Christmas and go through the whole thing and make sure you didn't miss the $100 gift card that Meemaw stuck in there because you were excited because you got the little teddy bear that you wanted, right? Go through the entire x-ray, find all the abnormalities. I know, I get weird analogies, but cool? All right, take 10, come back at 5-2, and then we're gonna do something a little bit more interactive.
I need you to get off your high horse, right? I can just feel that 98 coming off of you, and she's not a good one. I mean, hush.
just not wearing it.
You're
Just
gonna,
not wearing it.
you're gonna spread bad news around.
You're not wearing it, right?
I was reading this is good. So we talked about this, always a left lateral. Yeah, and it doesn't really matter, you can see both ones anyway. Even if I did a right lateral, I see both ones, it doesn't really matter. If it all looks the same, right, it's just like, these are left lateral, just as ratio, just kind of X-ray left lateral. Always going to be there.
You know, that's one thing, be like,
To avoid the magnification of the heart, is right lateral, the heart is really magnified, and really there's no reason. Yeah, that was interesting. So there'll always be a left lateral. There are no slides. There are no slides.
Oh, fuck no.
I didn't want to wait. I tried one of this small ones. They're so fucking sick. And then, but I went to the one that walked in. I guess they have something working on it. Walked in, took my car, took the call.
We got tomorrow, but
I have rotation in my clavicles, and that's not shit. That's because of rotation. You see what I'm saying? That's where that stuff comes into play, why it's important. Because we need to make sure that what we're seeing and it's not evidence of huge bad positions. So what I'm saying is, we're quite good. I have to look around, I'm looking for 50.
yeah.
I imagine it's like 2 hours. Yeah.
Right? On the flip side, if I have clear
I like that a lot.
okay, but when
don't hear lung cells on the same side. You can't have consternation. That is how we diagnose it. Yes, don't let it walk yourself out. That's what I want.
well, that's like that. Sorry about that. I'll just ask. So if I get fly back down.
I mean, you could take the vehicle to the airport and pay like $30. I know. I would pay $30. Well, also, her like, do I want to go really early?
I also don't think she wants to park her vehicle. I don't know.
I parked at a Baltimore.
That was good. You made that. She would rather we drop her off. She has a newer car. Even though, like, Pretty good. I don't care.
I'm just saying, like,
New spot.
if she doesn't care, she doesn't care, but if I was, I probably wouldn't want.
What you get?
Hey, yo, down in front.
Why are so much brighter colors?
It's gonna be hard when you're stabbing.
Back to back.
Like Ash Daddy.
Yeah, but like why is that one so much brighter? Why did that one? New spot. I was going to DVT. Oh, that's the number 50 now. Just looking at me. Just looking at me. Yeah. No, any Battlefield just ask for the class. Not Battlefield. For you. He's now up here. And I gotta keep my Battlefield in shape. I gotta look at my height. Oh my god. That's another journey. That's another journey. Oh my god. We had a guy 1 year, he was up here. You know what I mean? Like, I like this. He like did the whole thing. He like came in, like, you know, and then his wife obviously was. Oh god. There was like a picture of her. I have a. It was like 3 or 4 years ago. I was like, really, if I had that, my wife. We're always like, we always have my wife is very good at things, right? We're gonna have a family. She's like, trying to like make stuff out of like, you know, just like throwing stuff together. She's also a street like, watch out, throwing stuff together. She'll just be like sewing stuff and throwing cardboard in. So we'll see what I turn out to be. I think we're superhero families. That for a counselor. You know, like, Lottie will probably be a villain. Joker, oh my god. Have a Muriel Tusk with me and everyone wanted to be yourself. Have CB. We're gonna have CB
I got 160 and I didn't have Myers play. I got 160 and Myers didn't even play. Dude, Jackson Best picked up that so far. Yeah. 7 games in, I'm gonna get quarterback. Yeah, dude, look at this. I kind of shit the bed last night. 3 TDs, 1 reception, 5 carries, 14 yards, 1 rushing TD. Genty got the lowest, 21 yards. I'm rewatching it. Vikings defense. Devontae Smith, who went off. I had him on bench. And then Patrick Mahomes. Look at my top 3. 2, 0, 30, 13.
I was like, whatever you need to watch, she got you.
21 on the bench. Derrick Henry's coming back.
Maybe you might do that side versus this side.
Hope he's pissed. I lost all my. I won $4. Tatum subbed somebody out. Derrick Henry was on hers. And Myers went out. She ain't anybody should sub in there.
I didn't have any.
I'm right on the cutoff.
Okay, I think it's in your voice.
Yeah, I thought you wanted to do it.
I really don't get it. You know, we get so large.
I guess we should have a nap coming her way.
Extra sugars coming in my dietary. Well, per package, for 20 grams of sugar. Yeah, you're right. I need to weighted lunches.
All right, let's jump back in. Okay, so the second hour, we're gonna play with CTs, an actual CT that you can scroll through and actually get used to looking at a CT. Now, if you look on here, there's the top. You can roll them all down here all the way to the bottom and go all the way down. It lags a little bit, so like sometimes you gotta click and wait. There we go. All right. So you have your regular standard, and then you have the lung window where you can see that lung tissue really, really well. See the vasculature really well. This is not with contrast. This is just that lung tissue. Now I told you you can hit a button and it changes the algorithm and makes things kind of pop a little bit more. That's what this is doing. And then also over here you have your coronals and your sagittals. But here's the thing. I'm not going to bore you guys and just stand up here and scroll through a CT. You're going to entertain each other. So what I need is a volunteer. Anatomy questions could be on the test, so this could be pertinent. Come on up. And so what's going to happen is you're going to go up there, you're going to take charge of the mouse, and I'm going to give you an anatomical item. And I want you to choose whatever window, whatever slice, whatever you want to try to find that item, and then put your little mouse pointer over it. And because the first volunteers, they get the easiest one. I don't know how many slices it is, man. It's probably at least 32, but
64.
10.
I want you to find the carina. The carina.
What did you just call me?
It doesn't matter if it's a male or female. There it is. All right, round of applause. Yeah. And I used to just like ask for more volunteers, but I found out that it's more fun to see where everybody's loyalties lie. So now what happens is you get to pick the next person to come up and find something. Oh, what is that?
What is that?
Come on up.
I was about to go up too.
Oh, it's really fun to have you guys
I
pick
was about to pick you.
Don't do that.
Makes it more interesting.
I was about to
All right. Find me the glenohumeral joint. The glenohumeral joint. Now I like this lab, right, because it gives you guys a chance to kind of play with it and actually see what you can see on the sagittals, the coronals, the axials, the windows. Gives you a little bit of experience of understanding which ones to use. So pick a different one. Yeah, if you can't find it, go ahead and pick a different one. There's plenty of views that you can use. There you go. That's the one I would do. There it is. Have a seat. There you go, right? So you can see how you gotta annotate yourself, right? And kind of figure out where to go up and down and play with it. Pick your next victim.
Aaron.
Aaron.
Come on now.
The hardest one you got.
Left toe.
Fine.
Right. 2-7.
Give me a Fisher. Any Fisher.
Pick the bottom left, yeah.
Right around there.
I need to get closer. Got old eyes.
There you go.
Hell yeah.
Go to the left.
All right, I'll buy that. Can you find another one?
Go left one. Left one.
There's not very many, right? There's two in one lung and one in the other. So I mean, it's just.
Now go back to this. Right there.
That's the one I saw. Go more anterior. There you go. Keep going. Oh.
Oh, that's pretty good right there.
Go back one first. No, that's forward. Go back.
Oh, you see it?
No, that was it. That was in there. That was just making sure, right? So sometimes you gotta scroll back and forth to kind of make sure you're looking at. Good job. You can sit down. You wanna stay up here? All right, who's next? Who's next?
Victor's next.
Victor's next. Oh boy. Find me the splenic flexure of the large intestine.
What?
And you're like, wait, this is the chest CT. Yes, it is. And think about what each window shows the best. There you go. What I would do.
This one you said that's hard to see.
Splenic flexure. So think about what that is, where that would be, what other anatomy things can you use. Figure that out. Yeah, no, take your time to orient. Yeah, absolutely. It's the first time, and the reason I do this, right, is the first time a lot of you have ever kind of scrolled through like an actual CT exam. So it helps you kind of orient yourself, know how to use it, understand what you're looking at when you're looking at the body. You know, that way the first time you do it isn't in an ER in phase 2 while somebody's breathing down your neck telling you to read the image. There you go, so you got this, so that's spleen, perfect. So now if we're looking for the flexure, what part of the anatomy is that? The splenic flexure. There you go, keep going. Keep going. All right, so go back down just a little bit now. So you can go with that one or go one more. And then move your arrow up to where the bowel's at. Right in there. So everybody see that, right? So it's going to be that highest point, good job, that highest point of the bowel underneath the spleen. So how come I can see it on a chest CT? Because in order to get a full chest CT like the X-ray, I need all of that lung tissue. So when they scan that CT, you're gonna get parts of the liver, parts of the spleen, parts of the kidney, parts of the intestines, because in order to get all the way down to that costophrenic angle, we're gonna get some of the abdomen as well. Is this the best way to evaluate the abdominal stuff on a chest CT? No, it's not. But you're gonna be able to see it from an anatomy standpoint. Who's next?
Go with Alex.
Alex. Shakes his head. Then I'm not the bad guy. This is more fun. Well, at least for me it is. All right. Find me any rib vertebral joint. I don't care which one, just as long as it's one. Rib vertebral joint.
How do you get into it? Does it not work? Does it not work?
So what kind of window are you in right now? What's it called? It's on the little spot down there. Coronal lung window, right? So really useful for looking at lung tissue, not really useful for any of the soft tissue or bones or anything else besides the lungs. There we go. And now you can look for any rib vertebral joint on that axial, and you got it right there, right when the rib comes into the vertebrae. Good. All right, have a seat. Good job. All right, see? So a lot of it is just trying to think, a lot of it is trying to think again, what am I looking for? All right, we got a couple more on the chest one. Who's next? Oh, man. Right. Now, I will fully admit I may need to help you on this one. This one's going to be a little challenging. Because what is not on this CT? What do I not have on this CT? Contrast, right? So it's going to be a little tough, but sometimes you can still kind of pull it out. See, even though there's no contrast, if you can find the pulmonary artery. Can you find the pulmonary artery? Try to think back to the lectures and the slides and what shape that had and where it's at.
Is it right here? Yeah, that's what I was thinking.
Yeah, that does lag, so you scroll too quick. You're like,
Still
ah,
lag.
this stuff. So I would probably go back to that soft tissue window. Yes, right? Because the pulmonary artery is a vessel full of fluid. The hint is, nope, the hint is go back. One more, just stop, now just look around. Don't change slices. Move your arrow up just a little bit to your right, left?
Right.
Other way, right, up, stop.
Go right.
Yeah, right in that area, good job. It's hard because no context here, I'll show you right here. So I'm gonna, right here, so it is this guy right here. Up and down, up and down. Very difficult to find, right, because there's no contrast, so it doesn't stand out like that. Remember that pulmonary artery comes in, goes up, and then comes back down. That's where we look for what? What are we looking for when we give contrast for this and we do these?
Embolism.
Yeah, it's the pulmonary emboli, right? We see it all gray on here because there's no contrast. Can I tell if that's liquid blood or solid blood or clotted blood? I cannot because it all looks the same, right? But when I pump it full of contrast and it highlights bright white, if there's any of this dark gray sitting in this main vessel or down here, but you guys will focus on here for right now, that is a pulmonary embolism. That is clot. I'll do it over here as well. When we give contrast and it's all bright white, if there is any of this dark gray in this main vessel, that is a clot in the pulmonary artery. That is a pulmonary embolism. Okay, I remember that from way back when. What was the other thing we could use that to? If we look at the width of that compared to the width of what, and it helps us diagnose what? Do you remember? Pulmonary arterial hypertension, right? If the width of the pulmonary artery at its widest point, and we can't see it because there's no contrast, but you need the contrast, is wider than the ascending aorta, that's pulmonary arterial hypertension, right? You might see some of that on an x-ray. You might get the left atrial enlargement on the x-ray if you want the pathophys. That's what that would show there. But for you guys, like, also know that the CT will show that as well. Good. Let's see. Who's next?
Oh, definitely our class leader.
Class leader. Can't wait to do what the last one was. Can you find the esophagus?
Not the trachea.
What does this office look like on this?
No, you just say like this.
This is why we don't do CTs for esophagus. Just make your best guess. All right. I'll take it. I'll take it. Give a round of applause. Is there an esophagus there? Right? It's hard to see. I make this a point for a reason. This is not the esophagus. What is that?
Trachea.
The trachea. This is not the esophagus. What is that? So, if you ever see an anatomy question and it's asking you to point to things and it's a CT and esophagus is a choice, probably not a good choice. Can't really see it on the CT, right? It's collapsed. If anything, my argument might be, if I was thinking we'd have esophagus, might be this little guy right here. Because it kind of goes along with the trachea, right? And as I go down, it disappears in this collapse. But as I come down here, I got trachea. Maybe it's right there. Kind of disappears. Maybe pops back up here. So this might be, but again, I have no way to tell on CT because is that a vessel? Is that vasculature? Is that esophagus? Is it collapsed? I don't know, right? I do that one last for the chest in order to just kind of reinforce that yes, the trachea and the aorta are in the same general area as the esophagus, right? But you can see the trachea, you can see the aorta, you can't see the esophagus. All right, good job. Now, let's do some abdomen stuff. So here, I have multiple things. I have an axial non-con, okay? And then we have multiple axial contrast phases, and then a coronal for the contrast phase. When you give contrast to a patient, they have the ability, in this case, this is a three-phase kidney, they have the ability to scan it at different times, as we talked about, to catch the contrast in different areas. In the arteries, in the veins, or in an excretory phase. And that's kind of what I got here on this renal one. This is called the three-phase kidney. They do that and they catch it in the arteries, in the veins, and then the excretory phase. Your coronal down here is going to be only in your arterial phase. All right? So we're going to do some anatomy on that one. And Arnold, who you got next? Who's the one that's touched you the most? Because you just can't in the middle of the night? No. The one you wish would lose your number? All right. So let's do. Find me the left kidney. And you can click to any window you want, anything you want to do. Not kidney. A little too low for kidney. Why don't you switch over to that axial and that arterial phase and see if it pops up a little bit more. Remember what our organs look like when we're doing contrast. That works. Start at the top, work your way down. There you go. Left kidney, good work. Right there. So you see how the arterial phase, strong work. Yeah, that's it. Right? See how the arterial phase makes those organs pop more. Notice how hard it was, and some of you may have seen the shape, but how hard it was to distinguish on that non-con. Right? This is why we do contrast for a lot of our abdomen stuff, because now look at how nice the kidneys are. Look at how well I can see the liver. Who's next? Good thing we survived last semester, then. Whew. All right, so if you don't know your anatomy, let's do let's do the pubic symphysis. Oh, clever, clever. Clever, clever. Maybe. There it is. Good job, MC. Well done. You usually don't go right to the coronals to find that one. Well done. All right, who's next? Okay. Let's see if you can somehow find a Penn State win. That's a bad typo.
Not observed.
All right, let's do the pancreas. Let's find the pancreas. One of the harder ones. Look at all that stuff in the belly.
I mean, I would have found it by now.
Doesn't have to be calcified because we give contrast. So you can find it because it is a contrasted CT. If you were in the non-con slice, like good luck. On X-ray, you can't see it unless it's calcified. But on CT we can, especially if we give contrast. Scroll through a few more. Let's take a look. Keep going. Keep going. Well, go down, right? There we go. Keep going down. Good, good, good. Keep going. Good. So notice how it's on multiple images, right? So you kind of found the beginning of it. Go back to the beginning and show me where it was at. Right there, right? So there's part of it there. Don't have a seat. Good job. All right. So there's part of it here. Okay, yeah. Now, that's a hard one. It starts right here, right? So we know epigastric. So starting up here, the epigastric is where you want to go. Okay, so I got spleen, and what is that? I don't know. Okay, this looks like pancreas. Then my next slice, I got some of it over here, and my next slice, it continues over to here. I got some more here. So the pancreas is going to be on different levels, right? It doesn't sit perfectly horizontal, and so you got to kind of follow it. You are not finding that on an X-ray unless it's calcified, and you're also not finding it. Unlikely that you're finding it without contrast. Very, very difficult to see. All right, who's next?
Go ahead. You're up. Gotta get the study group.
Gotta get the study group. There it is. All right. Find me
Boo.
the iliac arteries.
Oh shit.
The iliac arteries.
Hurry up.
There are two ways to do this. There's the easy way and the hard way. I'm not going to tell you which way is the hard way. That's for you to figure out.
That's smart.
So the first part, in order to do this, you have to know bifurcate into bifurcate into bifurcate, right? And it's contrast, so they should be.
Oh. Boo.
So there's two ways to do this. So this could be, and the reason I say I don't know is because it depends on the person. This could be the easy or the hard way, depending on how well you know where those arteries are supposed to be, right? If you're not entirely sure exactly where the bifurcation is supposed to be anatomy-wise, then this makes it a little bit harder. But if you know what it bifurcates into, and as they continue to go down, then if you go to your arterial axial phase, you can follow your main aorta down into, up one more, there you go. And you can follow your main aorta down, and what's the first bifurcation off of the main aorta here? It lags, yeah, it goes slow. So what I want to show you is just kind of show you how, see how it bifurcates there? So this could be the easier or harder way. If you understand what bifurcates into what, then you can do this axial and you go, okay, main aorta bifurcates into, well, so the renals just kind of come off the side. The aorta doesn't necessarily bifurcate into the renal arteries, right? It should go into iliacs. So it's right here. It's those guys right there, right? As that goes further down, what does that turn into? Good job. Right? So as it goes down further, I'm watching these. So we got the aorta bifurcating, right? We continue. Oh, right here, right? I heard it, internal and external, right? And so now we're following these guys down. And then it bifurcates again, ironically, right by the femur. So those become my femorals. And they can continue to go down. So you can do it that way. You can just track this all the way down. This is beneficial when you run into those dissections. And I told you that dissection, you want to know how far down does it go. The CT does that. You'll see the gray line in the artery and see contrast on both sides of it because there's going to be a layer of tissue when that artery dissects, and you see it, and you follow it all the way down until it's back into one whole artery again. And that's where you can say the dissection ends at the iliacs, or at the femorals, or in the abdominal aorta, or wherever the case may be, because you can just follow that down. Now, this is a good one to use if you can just look at it and just go, okay, and boom, oh, look at that. This is the picture I thought you were going to grab. Right, but it lags, so it is hard to do on this computer. And then you can just go, okay, perfect, there's that. And then if you wanted to go further down and you understand that here's my femorals down in here, once I know where that's at. So the coronals are a lot easier if you truly know where they normally bifurcate at. But as you guys are learning, you do it through the bifurcation method. You can kind of go that way. All right, what else you got? Who else you got, I should say? I got a couple more. Megan.
You knew that was coming.
All right. Find me foreign body. A foreign body. Definition of a foreign body, something that is not anatomical, that is not there without being placed there in some way, shape, or form, either through trauma or other means. Find me a foreign body. I will give you a small hint. I did not tell you the name of the foreign body. Everybody else shush. I did not tell you the name of the foreign body because that would make it far too simple. Which means it is a common name, common foreign body. It's not the contrast. It's not a foreign body. I would recommend starting from inferior and working your way up. See if this one's got it. Go back to your, use the Venus phase will work too.
Right there.
There it is. Good work. Good work. Everybody see the IUD, right? So that is technically a foreign body, although it was placed there intentionally. That is a foreign body. So good. All right. One more. Who we got last? Last one. You almost made it out. You almost made it out, man. Oh, man.
Yeah, fuck that guy.
It's like Alice in Wonderland.
Yeah, how fast do you do this?
All right.
You gotta memorize.
Find me the psoas muscle. All right, find it on an axial. I want to come a little bit more superior. Think of where the psoas muscle is. Think of what part of the body it primarily is projected in. If you want to, you can go back to your coronal and get an idea of kind of where that's at from a height standpoint, right? So look at how we can use CTs. So go back to it for just a second. Look at how we can use CTs to turn around and go, okay, so on the coronal, point to where your psoas muscle was again, your primary area. Okay, so yeah, go up just a little bit though. Go just a little bit. Up, 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 up. That whole thing goes up there, right? So look at how I can use the coronal to go, okay, so this is right around here, and now I look at my anatomy around it. So now I can shift to my axial and go, I'm looking for something similar near the spine, just superior to the iliac crest. And so you can use both of these together to be able to pinpoint locations of things by using these different slices at times. Go for it, be confident. It's there, you got it, point to it. There it is, good, have a seat, psoas muscle, right? So I use that, I use that to show how you can use that coronal, that's why I had him go to the axial, to show you how it can be sometimes easier to see than others, but you can use both to be able to pinpoint that out. And I'll be honest, normally the psoas muscle is like the second one I did, but because that was the first attempt at the kidney, I didn't want to do that right afterwards. So I'm going to spread that out a little bit. But do you see how these things can be useful and how it is scrolling through them, how there's that delay and everything? Was it beneficial? Was it not? Yeah, maybe. Whatever. Put it in my reviews. But in all honesty, actually, when you do the reviews for this course, I want feedback on everything, but I really do want feedback primarily, not primarily, but make sure you include feedback on the labs, both block 1 and block 2. What was good, what you would like more of, what you'd like to see different, because that's the interaction part, that's the part where I'm really trying to put it all together for you guys, so I'm open to making adjustments. This idea came from a couple of semesters of student recommendations of like, hey, you keep showing us a CT slice, sure it would be nice to actually be able to scroll through a CT and kind of get comfortable doing that. So please, when you do the reviews, give me pros and cons to everything, but specifically the labs, if you have any. Because I can adjust these to whatever I want. There is no curriculum or syllabi thing that tells me what I have to present in the lab. It's just what I think is going to be beneficial for you guys for the course. Any questions for me? All right. Review still Thursday at 12? Yes? Okay. So review still Thursday at 12, I think. Hang on. I'll get with you. I've talked to Commander Grant on something, but I'll get with you. But review will still be this week, right? We'll definitely probably be in the Thursday timeframe to give you guys time to prep, study, go over it, and come back with your Q&A questions. That's all I have. I'll hang out here for a little bit.